a few housekeeping. Sorry, my things are stuck now. Questions, housekeeping. Reminder for the QA team, please mute yourself when not speaking, and please monitor the chat for questions you may be able to answer. And for all attendees, today's session is being recorded. Slides and webinar recordings will be uploaded to our link that we have there. To be added to the Hawaii VFC program email list, please email your request to hawaiivfc@doh.hawaii.gov. And in the subject line of the email, please write email list so that we can recognize that you're wanting to be added to our email list. For today's presentation, it will be on RSV updates for Hawaii, and it will be presented by Commander Torane Hall. He is the CDC Public Health Advisor for the Hawaii Immunization Branch. All right, when you're ready.
Good morning. All right, so my name is TW. Nice to meet all of you. We'll be talking about RSV today. A couple of things. By the end of this, we're hoping that you will be able to describe the RSV season in Hawaii because it's unique compared to other seasonality throughout the United States. And then we also want you to be able to kind of understand the RSV immunization recommendations. Next slide, please. So RSV in Hawaii is all year long. And next slide, please. The concept behind this is we do have a peak incidence season that somewhat mimics the continental US, as you can see on this graph here. But you can also see that we get these little, so after the major peak at the start of the graph, you can start to see these little bumps that go along throughout weeks, anywhere from week 52 of the year all the way to the start of the new year and in all the way back to July. And so with that, we need to protect against RSV year round versus the continental US that typically has a season that goes from about August until at the latest March. Next slide, please. So when we're getting into our recommendations and what has changed, keep in mind that RSV is still the leading cause of hospitalization amongst U.S. infants, and this crosses the border between healthy infants as well as those with comorbidities, right? So when we're thinking about this, we really want to see what's changed, and really our abilities to affect change come in two different forms, different than what we had at the beginning of this year, of last year. So in 2023, we had a couple of different medications that were approved by the FDA, and consequently, we had something significant happen with ACIP, with the Centers for Disease Control, and they approved a monoclonal antibody for the first time to be included in the Vaccine for Children's program. So some momentous things that have occurred, but let's take them one by one. So Abrysvo is a vaccine that was given, that was approved in August to be given to pregnant patients. And the idea behind this is very simple. We're going to give it in a specific window of time to the pregnant individual, and that will allow them to pass along those antibodies to their infant when they're born. Now, previously, Abrysvo was approved for the over 60 crowd to prevent them from getting RSV, and that was in March of 2022. So it's been around for a year and a half now or so, but it just got approved recently for the pregnant individuals. Now there's a second vaccine that was approved in March of 23, and that's RSV. And so want to make sure that we distinguish between the two, because RSV is not approved for the pregnant individuals, but Abrysvo is, okay? And then the newest kid on the block is Beyfortus, which is also known as nirsevimab, and that is a monoclonal antibody that's administered to infants. And the reason why that's exciting is because, next slide, please, because of the fact that we have a longer lasting monoclonal antibody as opposed to what we had before. So this monoclonal antibody protects for at least 150 days versus the previous monoclonal antibody that we used and we've used for years is Synagis, right? Which is also known as palivizumab. And palivizumab is challenging because of the fact that it has a very short length of protection. It's only 30 days. And so it was only used for those that were at their most sick to prevent them, or highest risk, to prevent them from contracting RSV. So we're excited about the longer lasting protection that nirsevimab has. However, the downside of this is that there's currently a national shortage. And so that's on both the public side, which is the Vaccine for Children's program, and the private side in terms of how you commercially order your vaccine products for your insured kiddos. So first, what we're going to do is we're going to talk about kind of blue sky recommendations. And what I mean by blue sky is when there's plenty of nirsevimab or Beyfortus available, there's a certain set of recommendations that we've gone through as the state of Hawaii and recommended. And then we'll also talk about what's going on right now, which is the fact that there's a shortage of Beyfortus or nirsevimab and how to kind of prioritize in times of that. Next slide, please. Okay, so when we're getting into the Beyfortus or nirsevimab recommendations, when it is readily available, we are recommending that, unlike some of the states in the continental United States, except for maybe Florida, I think is the only one that's considering a longer RSV season. But we're recommending year-round here in Hawaii for not only your Beyfortus, but also your Abrysvo, right? So both ways that we protect, right? We want to do that year-round because of that graph that I showed you at the beginning, in which we're talking about having those peaks that happen year-round. So when we're looking at this, we want to make sure that because we have two different ways to protect, right? Abrysvo is the vaccine, right? If it's given as a vaccine to the pregnant individual before they give birth, right? We can, if it's given before 14 days, so 14 days or greater, then that gives enough time for those passive antibodies to be transferred to the infant, and the infant's okay to then have some protection created. Now, there's a few circumstances that it won't necessarily provide protection, and we'll go over some recommendations later on for those caveats. But in general, if a pregnant individual gets Abrysvo greater than or equal to 14 days before they give birth, then we don't need to use nirsevimab. But if they do not, then we want to give nirsevimab to every infant year-round when we have enough to do that. And ideally, we want to give that in the birthing hospital. Okay, so if we're not able to do it in the birthing hospital, let's say that they have a birth outside of the hospital, or if for some reason there's a challenge in giving them right then with their birth dose of Hep B, then what we want to do is we want to give nirsevimab or Beyfortus within a week of their birth. Okay, so there is a recommendation for a second dose of nirsevimab or Beyfortus, but that's really only administered to infants that have continued high risk for severe RSV disease, and that's given between 8 to 19 months old. And you need to give it at least 6 months between the first and second dose. Now, you might be wondering, okay, so we've got year-round seasonality, and if you're doing the math and you're going, okay, so there's a chance that that if the birthday lands right and so on and so forth, that we really might consider a third dose, but there's no recommendation right now for a third dose for high individuals. All right, next slide, please. Okay, so in terms of packaging and what Beyfortus looks like, you've got two different options. You've got a 50 milligram dose, and then you've got a 100 milligram dose. So the 50 milligram dose is designed for the infants that are below 8 months old and weighing less than 5 kilograms. So really, you can see that for the most of the population, right? This is a birth dose, and after the first few months, they're gonna weigh out of this option. So that's when you got then your 100 milligram doses, right? And your 100 milligram doses are for infants that are below 8 months of age and greater than your 5 kilograms. And then you've got some individuals that are going to be in the high risk category of needing a second dose, or are kind of, working with a specialty. And those are the infants that are 6 to 8 months old. They weigh more than the 5 kilograms, and they're at increased risk for severe disease. And so they would still get a 100 milligram dose right up until the 8-month category. Then what we're going to do at the 8-month to 19-month category, if they have that increased risk for severe RSV disease, is we're going to give 2 of the 100 milligram doses, and that will come out to 200 milligrams as a total dose. Now, one other caveat that I want to mention here, while we can combine the 100 milligram doses to come up with the 200 milligrams, it's been made very clear by the manufacturer that we do not want to combine 250 milligram doses to come up with the 100 milligram dose. So let's say that you don't have any 100 milligram dose available at the time for a greater than 5 kilo kid. Then you don't want to combine the 250 milligrams. You really want to get the 100 milligram dose on board. Okay. Next slide, please. All right. So in terms of further comments about this administration, right? Ideally, what we want to do is we want to give that birthing dose in the hospital, right, in that first week of life, like we talked about. But for NICU infants, it's going to be a little bit different, right? So NICU infants might be on ECMO, they might be on these various processes that might filter out the antibodies in their blood, or they might have some extenuating circumstances in which their immune system isn't competent enough to really use these passive antibodies to best effect. And so for those infants, we want to delay vaccinating them until they graduate from the NICU. And so in those situations, you can have a preemie in a NICU for a few months, possibly, right? And so we'd wait until they got closer to the NICU and obviously talk with the specialist, because there might be a few instances in which you want to vaccinate prior to that. But for the most part, as a general rule, we want to delay vaccination until they're graduating from the NICU. All right. For infants age less than 8 months, right, we want to administer the Beyfortus as soon as it's available. And for children aged 8 to 19 months who are at increased RSV disease, then we need to administer it at least 6 months after the first dose. And so you can see, especially with the NICU, delayed graduation of these, where the 6 months then comes into play. If we've had us stay in the NICU for 3 months, now we're looking at month 9 that we'd be giving the second dose if they're at that high risk level, right? So these are these are intramuscular vaccinations, and they can be given with any of your age appropriate routine childhood vaccinations. Next slide, please. Okay, so let's talk about some caveats here. There are a few instances in which Beyfortus can be considered even if the pregnant individual has received a Brisvo, right? And so, and they still had a long enough period of pregnancy for the antibodies to transfer over to the infant. So we're talking greater than or equal to those 14 days. Now, those categories you can kind of deduce by critical thinking, but for the most part, right, those are going to be infants born to pregnant individuals who may not be able to mount an adequate immune response to the RSV vaccination, right? So these are individuals where the pregnant individual can't take that vaccine and produce the antibodies needed to be able to transfer it to the baby. Then your second situation is infants born to pregnant individuals who have medical conditions associated with transplacental antibody transfer, right? So now this is a pregnant individual that they can produce the antibodies, but now they can't cross the blood placental barrier, right, to get over and actually transfer those antibodies through, right? So those would be people, for example, people living with HIV infection. And then you've got the next category down, which is infants who have undergone cardiopulmonary bypass, or the ECMO, right? The extracorporeal membrane oxygenation, right? And what we're doing with ECMO, right, is we're part of it is we're filtering the blood, and so that can lose those maternal antibodies. So if you've got a NICU patient, they're on ECMO, then we're going to need to revaccinate them or re-inoculate them with a monoclonal antibody to get them to have that protection again. Then the last category is infants with substantially increased risk for RSV disease, right? So keep in mind, whenever we deal with vaccines and whenever we deal with monoclonal antibodies, we're dealing with a percentage, right? So it's no vaccine is 100% effective. And so even our strong ones like Hep A that are in the 90% range, there's still a percent chance that if we inoculate them with a vaccine, it still might not produce the desired effect and provide enough protection if they get exposed to that disease. And so if we have a really severe RSV risk, then we might consider trying to protect them again with the monoclonal antibody, even though the pregnant individual that they were born to got a Brisvo. Next slide, please. Okay, so in terms of Beyfortus recommendations in times of shortage, which we are currently in right now for the start of the 2024 calendar year, we want to do some, again, probably pretty common sense stuff, right? The first thing that we want to do is we want to strongly encourage pregnant individuals to get a Brisvo, and they have a short window to do that, right? They have 32 weeks and 0 days through 36 weeks and 6 days gestation to get that vaccination. And so we want to encourage that because there's not a shortage of it, and we want to try and provide that protection to the infants as soon as they're born. Now, for the infants that are less than 8 months, right? So we passed our window to give a Brisvo. Then what we're going to do is we're going to recommend kind of a staggered approach, if you will, for the providers, right? So we're going to recommend Beyfortus for infants born to patients who did not receive the RSV vaccination, the Brisvo, like we talked about, and then we're going to prioritize in the following manner. First, we're going to focus on those that have the increased risk for severe RSV disease. And we got a smaller population here in Hawaii of American Indian and Native Alaskan, but we do want to vaccinate those as well, those individuals as well. If you're curious about Native Hawaiian and Pacific Islanders, right now there isn't enough data to show that they are at increased risk, but we have encouraged individuals to start researching that area to see if there is research that would indicate that we would also include Native Hawaiian or Pacific Islander to this. But for right now, we're not prioritizing for Native Hawaiian and Pacific Islander. And then if we don't have nirsevimab or Beyfortus available at all, then what we want to do is we want to follow the recommendations of what we used for years, which is the Synagis or the palivizumab, right? And we're going to use that for the infants throughout the age range all the way up to 19 months. I know that the slide here, we're talking about age 8 months, right? Because we're talking about the infants in that slide range. And then on the next slide, we'll go from there. But keep in mind that basically Synagist is kind of our old standard, right? So when we don't have Beyfortus available, we want to default back to how Synagist has been used in the past. All right, next slide, please. So when we're getting into times of shortage and we're dealing with the second dose, right, of nirsevimab, Beyfortus, and we're still in times of shortage, right? So these are going to be the 100 milligram doses that we're doing. Then we want to again prioritize those individuals that have that continued higher risk, right? And then for those individuals that have higher risk, we want to further stratify that by those living in remote regions and communities, right? So this is areas where we know that the transportation time is going to be long. So those living outside Oahu, right, that would require air transportation to receive higher level of care for RSV infection. And then again, our American Indian and Alaskan Native who are not Synagist eligible. Okay, and then again, we want to use the Synagist for the palivizumab eligible children, just like we did for those under 8 months, if we don't have nirsevimab available at all. Next slide, please. So let's talk about the high-risk categories that we want to kind of stride for nirsevimab. And so we put this onto one slide for you all to be able to kind of go through this, right? So again, first season, right? We're talking about those that were recently born, right? Ideally, we want to vaccinate those in their first season in the birthing hospital if we can, or that first week of life. But the ones that we're going to prioritize in this when we don't have enough are the premature births, right? So less than 29 weeks gestation, those that have chronic lung disease of prematurity, those that are hemodynamically significant congenital heart disease, those that are severely immunocompromised. We're talking about those that have severe cystic fibrosis, so either manifestations of severe lung disease or wait for length less than the 10th percentile, those that have neuromuscular disease, and those with congenital pulmonary anomalies, right? Abnormalities that impair their ability to clear those secretions, right? So anytime we have the loss of the ability to clear secretions, then we're kind of dealing with a more muddy soup in the lungs and a greater risk for infection to take hold in that area. Now for the second season, right? So these are the individuals that we're talking about that are between the ages of 8 to 19 months, right? We're talking about a smaller grouping, right? So we're talking about those that have the chronic lung disease from being born premature or requiring medical therapy for their lung disease. We're talking about children who are severely immunocompromised, the children that have the severe cystic fibrosis, right? And then the American Indian and Alaskan Native children. Next slide, please. So when we get into Beyfortus ordering, a couple of things here. Number one, as we've stated, we have limited doses across the board, and when I'm talking limited doses, I'm talking less than 1,000 at this point in time, right? So we're talking about a much smaller amount for our population when we have several hundred bursts a month. So your orders for the VFC, the public supplied vaccine, are going to be reduced or waitlisted. And so just keep that in mind. We're talking about very limited quantities, so we want to kind of spread that out and make it as equitable as we can. Due to that extremely limited supply, right, the VFC ordering of the 50 milligram presentations will remain restricted to birthing hospitals only. So birthing hospitals only are going to be where we initially and we have been staging the 50 milligram doses. Now, any VFC provider can request the 100 milligram presentations to administer for VFC eligible infants in Hawaii, but keep in mind, again, a very small amount. So we'll do what we can to make that equitable. Okay. But you need to use the VFC nirsevimab monoclonal antibody ordering form to place these orders, because again, they're under a kind of a specific protocol here for us to try and keep track of it and make sure that there's equitable distribution. Next slide, please. So here's some of the nirsevimab ordering details. You can see the NDC codes, the product presentations, the weight indications, and again, some of the things that we talked about before in terms of the 50 milligrams being available only at the birthing hospitals and the 100 milligrams being available for all the VFC eligible infants and providers to be able to order for those infants. Next slide, please. Okay, so now that we've kind of gone over nirsevimab in Beyfortus in the both of the times where we have limited supply and in the times where there's bountiful supply, let's talk about Abrysvo. So Abrysvo vaccine is just as equally recommended as nirsevimab and nirsevimab Beyfortus, right? So there's not a preferential recommendation to use nirsevimab when it's available or use Abrysvo. Either one's going to provide good protection for right now. Now, more research will be coming on this, and we'll see if we end up developing a preference as the research comes out. But for right now, there's no preference, right? So for Abrysvo, for the VFC program, so keep in mind the VFC program is for those individuals to age below 19. There is the ability, ACIP did approve Abrysvo vaccine for the VFC population. So these are Medicaid eligible folks that are under 19. These are uninsured, right? So this is someone who has no health insurance. This is American Indian or Alaskan Native, and then the underinsured, right? So the ones that won't have full coverage of vaccine under their private health insurance. Okay. Let's go ahead and go to the next slide. When we are looking for Abrysvo recommendations for the pregnant individuals, like I said, we got only 6 weeks, basically 6 weeks and 6 days to get that vaccine in during their pregnancy, right? So we want to make sure that we get it in between 32 weeks and 0 days and 36 weeks and 6 days gestation, right? And like we talked about, there's no preference of Abrysvo versus Beyfortus at this time. But we have ample supply of Abrysvo, so that's why we're recommending Abrysvo be encouraged with all pregnant individuals. Okay. Now, keep in mind that like we talked about, if the 14 days incubation period after an Abrysvo vaccination, that's the golden standard right now, right? So if we have a birth prior to the 14 days, then we're not sure how great the protection is going to be to that baby, because we don't know how much of those antibodies have been transferred over, right? So that's, if it's under 14 days, that's where we're going to recommend nirsevimab if it's available. But if they can go beyond 14 days, equal to 14 days or greater than 14 days, then we know that the Abrysvo has had enough time to transfer those antibodies developed by the mom to the baby for protection. Okay. I think that covers this last point. Let me just see here. Maternal antibodies provide the passive immunity that we talked about the last several months. And of course, the RSV vaccination, Abrysvo for the pregnant individual, also protects that individual from getting RSV as well. All right, next slide, please. So, like we stated already, there's no current shortage of Abrysvo supply. So, highly encourage this as a way to protect our keiki at this time. Keep in mind, Abrysvo is not recommended, right? So very important here. Abrysvo, there is no RSV vaccination at this time that is approved for infants, children, and non-pregnant teens, right? We're switching to a monoclonal antibody, right? The nirsevimab for the little ones, right? And so just keep that differentiation in your head. We don't want to be giving a Abrysvo vaccine to an infant. Okay, that's nirsevimab and the monoclonal antibodies region at this time. All right, so there's also no current recommendations for additional doses of Abrysvo for subsequent pregnancies, right? And then keep in mind what we talked about in the beginning, their RSV that was just approved in March of 22, right? That is not currently recommended for pregnant individuals, right? So Abrysvo is the only RSV vaccination that we can give to our pregnant individuals. Next slide, please. Okay, so in terms of the Abrysvo ordering for VFC, right? So remember, VFC under the age of 19. So we're not going to recommend that it's routinely stocked, right? We're going to do a special ordering system with the Hawaii Immunization Registry, right? And this is only for administration of VFC eligible pregnant patients, right? And so, and of course, they need to be in that right gestation period between 32 weeks and 0 days and 36 weeks and 6 days. Okay, so you can order this, but you can only order this from a VFC provider that has a specific VFC eligible pregnant patient that's ready to receive it, right? So we're going to give these out dose by dose, basically situation by situation. Next slide. Okay, so just a slide here at the end to talk about Synagis, palivizumab. Remember, we've talked about this a little bit already, but palivizumab or Synagis is kind of the old kid on the block, right? It's been around for a while, and due to our shortages, that's kind of our stopgap until we get more nirsevimab availability, right? So just some points on Synagis, some reminders, right? It is a monoclonal antibody, but that duration of protection is only 30 days, which is why they need to have monthly dosing indicated during the RSV season for those infants that are high risk, right? So you'll be working through that. It is recommended by CDC and the American Academy of Pediatrics that if nirsevimab is unavailable, that we continue to use this. Once Beyfortus does become available or nirsevimab becomes available, then that infant, if they've received less than 5 doses, then the child should receive a 200 milligram dose of Beyfortus nirsevimab no later than 30 days after the last dose of Synagis. Okay, so we're talking about we're giving Synagis because Beyfortus isn't available. We give it. As long as we give it less than 5 times, then we want to give a 200 milligram dose of Beyfortus or nirsevimab, and we want to do that within a 30-day time period before the last or since the last Synagis injection. Now there is not a minimum interval between Synagis and Beyfortus, so if Beyfortus becomes available and it works for everyone to give it at that 15 days after the Synagis shot, that's absolutely okay. Okay. Once you've given the Beyfortus, then you don't need to do any further doses of Synagis required. Remember, we've got a long-acting on board with the Beyfortus or the nirsevimab up to 150 days, right? Okay. Now, the last thing to consider is that Synagis is not included in the VFC program, and it's been recommended by the American Academy of Pediatrics that you call to get insurance authorization before you give it in these cases. So make sure that you get pre-approval so that you won't have any hiccups in your billing. Okay, I think that concludes our discussion today. So let's go ahead and go to the next slide and let's open it up for any questions that might have come in.
It looks like we don't have any questions as of yet. Anyone have any questions before we conclude today? Thank you, TW, for your presentation. Very, very helpful information, especially during this time of shortage with the nirsevimab.
My pleasure.
Okay, if we don't have any questions, we do have our contact info. Should you have any questions for HIR, technical login issues, you can contact the registry help desk because that is something that we do have questions a lot on. You can contact their registry help desk at 808-586-4665. And for the neighbor islands, it's 1-888-447-1023, or you can email them at registryhelp@doh.hawaii.gov. For immunization clinical consultation, you can call us at 808-286-8349. And if you have any VFC related questions, you can contact our Q8 team. There is our contact info. And we do ask that if you can complete our webinar survey, it'll ask you questions on if the timing is good for you or any other topics of interest that you may have. Thank you for joining us today. If you have no other questions, that concludes our presentation for today. We will be having our virtual office hours until 10 this morning. So if you have any other questions, please feel free to pop back in. You can shoot us a message in chat or give us a call. Thank you. Have a great day.